And welcome to this ODI webinar on development finance institutions and the pandemic response, in which we will focus today on how DFIs are investing in healthcare. This is the second of 3 webinars and is organised in partnership with the CDC Group, the UK's development finance institution, Proparco and DEG, the French and German equivalents, and EDFI, the Association of European Development Finance Institutions. We're delighted today to have such a large audience joining us, with over 130 participants from Africa, America, Asia, etc. My name is Sam Attridge, and I'm a Senior Research Fellow here at ODI, and I will chair our discussion today. So we at ODI recently reviewed the portfolios of 8 development finance institutions to understand more about their investment in the healthcare sector. From our analysis, we found that DFI investment is relatively low and is largely directed towards infrastructure and pharmaceuticals in upper middle income and lower middle income countries, with a significant concentration, in particular in Turkey and India. However, we also found that this kind of pattern of investment is not necessarily inevitable, and we found lots of interesting examples of high risk taking and innovative approaches, such as the use of volume and first loss guarantees, cross-subsidisation models, development impact bonds, and pooled investment vehicles. So, informed by this research today, we shall start by discussing the immediate DFI response in healthcare, and we'll get the panelists' perspectives on the current state of DFI investment in this sector. We shall then look forward and explore whether these patterns are actually inevitable or can they change, what innovation may be required, and how complementary is DFI investment to public investment in health. But before I introduce our stellar panel today, I'd just like to highlight a few housekeeping rules. We very much encourage questions to our panel. If you have any, please enter them in the box below this video or audio stream. Additionally, please use the hashtag Investing to Save Lives or hashtag DFIs to tweet your questions and comments about this event. You can also find us at ODI Dev and at CDC Group. Please note also that our panelist from Proparco, Claudia, has to leave us at 1:45. So if you have any specific questions you'd like her to answer, please raise these and I will ensure that she answers those before she leaves. So without further ado, I'm thrilled to introduce our distinguished panel today. And in no particular order, we have Claudia Martinez Ochoa, who is a Senior Investment Officer in Manufacturing, Agribusiness and Services at Proparco, the French Development Finance Institution. Claudia has been an investment officer at Proparco for 5 years, and prior to that was at the Inter-American Development Bank as an investment officer focused on bottom of pyramid transactions, including healthcare. Next, we have Al-Karim Haj, who is the Vice President and Chief Financial Officer of the Aga Khan University, which operates health services and academic programs in 6 countries. Al-Karim is also the chair of the Aga Khan Development Network and the Health Purchase Network Committee that consists of 21 hospitals, 750 medical centres in 12 countries, treating 9 million patients annually. And finally, we have Michael Anderson, who is the Chief Executive Officer of MedAccess, a UK-based social finance company with a pioneering mission to make global healthcare accessible for everyone. He has over 30 years international development experience and has held many prominent positions, including as the Chief Executive Officer of the Children Investment Fund Foundation, the Director General of DFIs, and has been the UK's Prime Minister's Special Envoy on International Development. So welcome, panel. Let's first spend some time discussing the current state of DFI investment and the response to the pandemic. So I'm going to turn the floor to Claudia. So Claudia, Proparco is one of the few DFIs who make investment in the healthcare sector. What has been the impact of the crisis on your healthcare clients, and how have they responded? And how has Proparco actually supported these clients in that response?
Hi to everybody. Okay, so we've seen two basic impacts on our clients. One was liquidity problems as a result of the crisis, and the other was insufficient protective personal equipment for hospitals and clinics. So first I'll touch on liquidity issues between hospitals and clinics and pharma. So hospitals and clinics saw a drastic reduction in revenue and levels of activity as countries across the world imposed lockdown measures, and non-urgent operations were cancelled either by law, by patients, or by hospitals themselves, as they were trying desperately to free up beds to receive COVID patients. And in many countries, governments actually imposed a quota on private hospitals to ensure that a certain number of ICU beds remained available at all times to receive COVID patients, but were not remunerated for those beds. So that also hurt their bottom line. On the pharma side, the greatest concern was supply chain disruptions. So pharma producers across the world import about 80% of what we called active principal ingredients from China. That is the main raw materials needed to produce pharmaceuticals. And when China went into lockdown in January, our small pharma producers alerted us to the fact that they had limited inventory of certain APIs, and if that the Chinese economy and exports did not open up by April, they would run out. I would not be able to produce basic things like paracetamol. And this affected not just small producers, but large producers as well, as we saw many countries, even in Europe, at some point risking having shortages of paracetamol and other basic medicines. So that was on the supply chain. Additionally, governments in emerging markets started redirecting their purchases, focusing on COVID-related medicine and putting aside other essential medicines like anti-malaria treatments and vaccines, which hurt our pharma producers focus, for example, in Africa on essential medicines and generics, and they had to scramble and try to find new APIs and new distributors to increase their portfolio and be able to provide these to governments. But that also hurt, obviously, their bottom line. And then finally, part of the disruption process in the supply chain was that Chinese exporters of APIs, when they restarted exporting in around April, they began to demand tighter payment conditions with much shorter payment delays. And at the same time, local distributors and local governments in emerging markets were having liquidity issues, and so were asking pharma producers for longer payment delays. So pharma producers were squished between their suppliers requesting immediate payments and their clients requesting longer payment delays. So that created serious liquidity problems for certain customers. What we did as a result of this was to react as quickly as we could, and we deployed two instruments. The first one was emergency COVID grants that we had never been able to do in such a short period of time. And for example, one of our hospitals in Central Asia, we gave them an emergency grant so that they could acquire protective personal equipment for their staff, as their country was lacking, and they desperately needed to equip their personnel. And the other instrument was working capital lines. Same thing, emergency working capital lines. For example, for the pharma producers, they needed to bridge the gap. As I just mentioned, all these disruptions meant that their capital was stuck between suppliers and clients and lower revenues. And we helped them overcome, let's say, the summer months, which were the hardest because production was lower due to social distancing, production lines, people couldn't necessarily get to work because public transportation was disrupted in many countries, etc. Now hospitals are about 80 to 90% at capacity in the country, in emerging markets, and our pharma producers are also about 80 to 90% production, in some countries 100% capacity. So that was basically the story and how we were able to react.
Okay, super, showing some of the flexibility in Proparco's response. Just very quickly, if I may, you mentioned about the emergency COVID grants to help acquire PPE and working capital lines. Was this, you've never done that before? You've never had access to these kind of grants, or kind of what's your approach on the working capital? Just briefly, just to tell us a little bit more about that, please.
We did have access to grants before, but the process was long. And you had to pass clients through committees, and it could take up to 6 months. So we were basically able to shorten that into a 20-day period, working long hours by our teams, but trying to get proposals quickly to our committees. Our risk department rolled up their sleeves and were super responsive and helped us get answers quickly, because that they need to approve those grants. And from the working capital line, same thing. We basically had to make the case that you had two options in front of you. Either you gave them an emergency working capital line, you crossed your fingers and you hoped that would push your client over the impasse and into better times, or unfortunately your client would go down with COVID and you would lose your investment. And obviously, at least collectively, it never crossed our mind that we would let a health provider or a health company go down because of COVID. And we decided it was best to risk more capital and make sure we made our argument correctly and push them over the line into September. And that's thankfully what occurred.
Okay, wonderful. Thank you. So, Michael, as I mentioned, our recent research found, I would say relatively small numbers of examples of kind of risk-taking and innovative kind of approaches by DFIs. But MedAccess was one of those kind of examples that we came across and were interested in. So can you briefly explain to us the kind of the innovative MedAccess model and its response to COVID-19, please?
Yeah, very happily, Sam. I just want to say at the outset that what Claudia has described sounds really familiar to me. Within CDC, there was a huge amount of scrambling to get grants out for emergency PPE to support companies, a lot of late night working and innovative compression of timelines. I think that's been shared around the world. I do want to talk about what we do, because what we do is fairly unusual. So MedAccess is a subsidiary of CDC, created 2.5 years ago. We have $200 million of paid-in capital from CDC. We are a social finance company, which means that we're not looking to make a profit. We operate like a business, we're commercially sustainable, but we're not for profit. Our mission is to make medicines and other health products affordable and more widely accessible in low and middle income countries. So that's our core mission. And we do that through guarantee financing. So guarantees are really the core financial product we offer. And in particular, we were founded especially to provide volume guarantees. The way that volume guarantees work is that we partner with companies who have products, normally products that are being sold in fairly low volumes at higher prices, particularly in low and middle income countries. And we help to de-risk the movement of those companies into markets that are perceived as being riskier. We do that by providing a floor level of guaranteed sales over a period of years that we will guarantee. When sales fall short, we will step in and make them whole. In return for the guarantee on volumes, the company commits to a price ceiling. So everyone gets the certainty of knowing there'll be a certain amount of volume and that the price will not go above a certain level. That creates trust all around. So that's the way we work. Just to give an example of a company we've partnered with, partnered with a US firm, a diagnostic firm called Hologic, partnered with them to help allow them to bring their product for HIV viral load testing into Africa at a 30% price reduction from what was prevailing in the market. In the first year, 2019, our epidemiologists tell us that an estimated 182,000 patients living with HIV benefited and got better clinical outcomes because of this testing coming to market. And the really great technology is being disseminated widely, which otherwise was not there several years ago. So that's an example of what we do. I'm saying that by way of background to our COVID response. For MedAccess, our COVID response was we worked very quickly to find ways to help support companies to get products into market. And we ended up doing a $50 million guarantee for UNICEF, a procurement guarantee, allowing UNICEF to secure volumes from manufacturers of PPE, oxygen equipment, diagnostic tests, those volumes that would otherwise really difficult for small countries with very little negotiating power to get. So UNICEF accelerated procurement of those products and got them out to country. And I'm pleased to say that with backing from CDC, our parent company, we were able to provide that guarantee without any fee whatsoever. And we compressed our due diligence process to get it done very quickly. And we took on more risk than we normally would.
Super, thank you, Michael. Just reflecting, if we're 6 months into the pandemic, what kind of innovation have you observed in DFI health investment in response to the pandemic? And do you think it's enough? Or what kind of role do you think DFI should be playing?
Well, I do think that the core function of DFIs in this time has been to provide counter-cyclical financing for a range of businesses and ensure those businesses are secured. So CDC, our parent company, for example, they had 3 strands of activities. First, to preserve the companies that they support, to ensure that employees are safeguarded with the right kind of equipment and they've got the right kind of capital to continue business. Similar in some ways to what Claudia was talking about. Second, to strengthen, to scale up local liquidity, trade finance, local finance, to make sure that there's the liquidity in the market to keep products and services going, to ensure basic needs are met. And the third strand for CDC is to rebuild, to invest more, including in thinking about how do we create sustainable long-term health systems. It seems to me that that's right. I think the challenge for DFIs is how do you invest effectively in, really, really short time scale? How do you invest effectively in scaling up health products? I have to say that the biggest risks that were taken in COVID were really taken by entities like governments, US BARDA, the Department of Health in the UK, some really big bets made on innovative products and long-scale products. There were also risks taken by finance ministries who are willing to engage in deficit spending at an astonishing level, historically unprecedented. And third, big philanthropies like the Bill and Melinda Gates Foundation were able to take really big bets. If I look to private finance, and just excluding DFIs, but I look at private capital has actually taken very little risk during COVID, little new risk. It's taken quite a lot of risk thrust upon them, but really has not, in my view, responded with the risk-taking that one might expect from private finance. And that's quite surprising, especially with interest rates being as low as they are in capital at the moment. I think for DFIs in particular, it's a more difficult place to operate, but I think that there is now a real need to continue to focus on the long term. I suppose if I'm completely honest, I'm pretty proud that we took exceptional measures. I think that many organizations have had bold initiatives, but I do think we haven't seen enough of the innovative approaches. We haven't seen enough of the new products, and we haven't really seen the shift to taking a lot more risk that one might have seen or might have expected in these times.
Okay, super, Michael. Perhaps I think when the second part of the webinar, when we look forward, we can maybe probe a bit more on kind of that innovation and risk-taking. If I move on to Al-Karim, the Aga Khan University Hospital in Karachi has been the beneficiary of investment by a number of DFIs, including Proparco and the US DFC. It's super interesting because we came across this cross-subsidisation model where wealthier patients pay more and subsidise access by poorer patients. Some, as we know, kind of would have an ideological view that private investment is not as good in the health sector, but your model sounds like a good model about the complementarity and access. So can you reflect on this and tell us a bit more about the DFI investment in your hospital and the cross-subsidisation model, please?
Thank you, Sam. Let me just start by saying it's a pleasure to be part of this panel to discuss these important matters. I'm going to start really by addressing the perception issue about the role of private healthcare. And I respectfully disagree with the notion that some have that there is no place for private institutions in healthcare. Why do I say this? I say this because governments simply cannot meet the needs of their growing populations on their own. And many of the countries we work in fact, in all the countries we work in, Pakistan, Kenya, Tanzania, Uganda, Afghanistan, government invites private sector participants. But I must point out that we are a not-for-profit institution. We are not a for-profit private institution. And so I know sometimes there's a hard time some have in distinguishing the two, but all of the income that we generate is used and reinvested in the countries we operate in to support indigent patients, to support academic programs that build critical human resources for health. And if you will just forgive me for a minute or two more, I just want to explain why this is so fundamentally important and how this fits into the way we look at investing and cross-subsidizing. When His Highness the Aga Khan built the Aga Khan University and the Aga Khan University Hospital in Karachi, he did so to be an exemplar, to ensure that a high-quality higher education institution and healthcare organization could be established in the developing world. Why? Well, his fundamental belief is that every human being has a right to high-quality education, high-quality healthcare. Being born in a marginalized setting or in a developing world gives you no less right than if you were born in an affluent family or in an affluent country. So very important, this concept of social equity. And if I may, what have we done, and forgive me because this will sound a bit self-promotional, what has one private health institution has been able to do in Pakistan? We commissioned an economic impact study done by the Centennial International Group based in Washington, D.C., and they looked at what the impact of the Aga Khan University and Hospital has been. Very quickly, AKUH, after dozens and dozens of interviews and focus groups and evaluating data, came to the following conclusions. Number one, AKU has been an exemplar for healthcare in Pakistan. It has raised the standard. It was the first Joint Commission International Hospital. Now there are two more. The one and only College of American Pathologists laboratory in the country. It has a medical school that is ranked by the Shanghai rankings as the only medical school in clinical medicine in Asia in the top 100 in the world. It's introduced to training in many specialties and subspecialties that have never existed in the country. Others have now emulated that. The School of Nursing and Midwifery has played a critical role in women's empowerment. It has done it was the first institution to take nursing from an apprenticeship model to an academic model. And most of the deans of accredited nursing schools in Pakistan are actually the alumni of our School of Nursing and Midwifery. So overall, I hope that provides some evidence or an example of why private healthcare organizations have a role to play. Now, with respect to the cross-subsidization model, in Pakistan, we borrowed $53.5 million from the U.S. Development Finance Corporation and the French Development Agency, AFD, and also the Aga Khan Foundation in the United States. DFC provided us $30 million, Aga Khan Foundation $7.5 million, and AFD $16 million. The funds from DFC and Aga Khan Foundation were really to expand our health infrastructure, critical care beds, new hospital beds, all operating matters to improve the nature of services that we offer. In addition, the $16 million from AFD was really used for infrastructure, energy efficiency, and environmental sustainability investments to reduce the carbon footprint. We're very grateful to our partners for that investment. Expanding the hospital allowed us to generate more income. What did we do with that income? We were able to subsidize, last year, we subsidized nearly 900,000 patients. Those patients who could not afford to access our healthcare were given some form of subsidy so they could access that. And then we cross-subsidized the training of doctors, nurses, and allied health professionals. So insofar as the model of cross subsidy, those patients that can afford to pay, they pay full economic cost. The income that's earned from that, the margins that's earned from that, goes to cross subsidize those patients that can't afford to pay for those services. And we believe that that model is sustainable. It's been in place for 35 years. It's being replicated in other hospitals that we have. So overall, we do believe that this model has merit. It has worked for us within our group. So thank you, Sam.
Super, thank you. It's great to hear on the ground, and especially about that cross-subsidisation model. Okay, I was wondering if there are any reflections from the panel on what you've heard colleagues say. We've got a couple of minutes to just interact between ourselves. If anything was flagged which you'd like to comment on or struck you, Michael, do you have something?
Yeah, I just think the model that Al-Karim has been around. It's proven. It's worked really well. Capital investment that is willing to look for that cross-subsidization as an outcome in place of returns. And we need to think carefully about how do we structure investments so that kind of explicit cross-subsidization can be built in.
Okay, Michael, unfortunately, I don't think we could hear you, but maybe I'll just move on to Claudia, who signaled that she'd like to make a comment. Claudia, over to you.
No, I would just say that, Al-Karim, what you mentioned on the importance of private sector healthcare, I couldn't agree with you more. Obviously, it's also sort of self-promotion because that's what we invest in. But regardless of that, the need is so tremendous that it is impossible for one single government to provide, to cover 100% of the population. Having said this, I think both are complementary, and I'll touch upon that a bit later in one of my answers. But there's models where there's universal health coverage and there's no issues on affordability, and governments are able to cover 100% of health costs through private and public providers. So I think regardless, it's not even a question of affordability in my mind only. It's also a question of actually access to infrastructure that governments don't necessarily need to be the ones building and operating hospitals. Private sector can actually do that quite well. And it's more a question of regulating the entire sector so that both parts are complementary and the entire population is able to have an adequate health coverage.
Okay, super, Claudia. So maybe now if we just kind of look forward, Claudia, as I said earlier, in our review of DFI investment, we found that DFI investment in the health sector was relatively low or small and largely directed towards infrastructure, which you've just spoken about, and pharmaceuticals in middle-income countries. Is there something about this kind of subsector which makes it more attractive for DFIs such as Proparco to invest in? And can DFIs change this pattern of investment? And if so, how?
Okay, so I would say that there's two reasons why DFIs do what we call hard asset investment. One is financial and one is developmental. So the financial reason is because our main instrument is long-term debt secured by assets. DFIs are usually not competitive with short-term instruments. We actually prefer to leave that to local banks because we do not want to crowd them out. And we think that our additionality is actually in providing access to long-term capital, as this is the instrument that is needed to build large infrastructure projects such as hospitals, clinics, and pharma factories across developing markets. And then the second reason is, as I said, developmental, which is basically the need, as I touched upon a couple seconds before that, of expanding access to health services across emerging markets. And I'm going to give two concrete examples in the two sectors. So on the pharma side, in sub-Saharan Africa, 90 to 95% of all pharmaceuticals are imported. And the number of local producers are not only few, but on top of that, very few of them comply with the WHO good manufacturing practices. And so we believe that it is at the core of our mandate to support local producers, particularly in sub-Saharan Africa, to increase local production, but also to reduce its dependency on imports that can create shortages in medicines when currencies become volatile, or you can see very radical devaluations, as has been the case in Zimbabwe or Venezuela. Concerning hospitals and clinics, the story is similar, is one of access. There's still a severe lack of beds across emerging markets. I'm going to give an example of one of the best in class to show that even one of the best in class in a middle income country faces this. So the example is Colombia, middle income country, OECD member recently, and has a fantastic healthcare system that provides universal health coverage for its population, with obviously a lot of things to improve. But to give statistics, back in 1990, only 10% of the population had access to healthcare and was covered. You fast forward to 2020, 95% of all Colombians have universal health coverage. No single Colombian faces a problem of affordability. 100% of all medical expenditures are covered by the Colombian government, exactly as would be the case in France. But, big but, Colombia has only about 1.4 beds per 1 million inhabitants, compared to an average of around 5 for the EU. And most of these beds are located in urban centers. So even though affordability in a middle-income country is no longer the issue, and anybody can go and get treatment, they might not be able to find a hospital. The COVID crisis, on top of that, made us double-click on that statistic, and you look at the amount of high-complexity hospitals and ICU beds, the results are even starker. So again, to give you a quick example, France at the beginning of COVID, 60 plus million inhabitants, around 5,000 ICU beds. Colombia, 50 million inhabitants, so not far off, had about 2,000 ICU beds. So half for almost the same population, which sort of shows that affordability is the first challenge, but then you also need to tackle the issue of access, and of course the issue of quality. Then with regards to the geographical question, as I said, all countries, middle and low income, are in need. But from our standpoint, our focus remains Africa. Simply, it is a little bit difficult sometimes to find bankable deals in the health sector in sub-Saharan Africa. And the example I just gave on the pharma side, on there being very few producers and very few being WHO GMP compliant, is crucial, because we cannot invest in companies that do not respect a minimum level of quality standards. And with the WHO standards, these have very concrete repercussions with it. For example, the physical design of a facility, of a pharma facility, that you cannot remediate if the facility has been built incorrectly. For example, you have to separate physical production of what we call beta-lactam, so penicillin and antibiotic production, from non-beta-lactam production. Why? Because otherwise somebody who's allergic to penicillin might die from an allergic reaction by taking one paracetamol that has been contaminated. And as such, that is why those types of productions are not compatible with WHO standards. One of our recent investees, AfriCure, it's an Indian-based company that invests and operates only factories in Africa and in India in generics, and we gave them a $10 million loan to construct factories in Ivory Coast, Cameroon, and Ethiopia. But we also had to give them an 800,000 euro technical assistance grant, so they could train their staff and they could conduct regular audits to make sure they were always WHO compliant. Noting that we, during due diligence, had to confirm that their existing facilities were already designed to be compatible with WHO. The reason for this is because the local regulatory frameworks, unfortunately, the regulatory authorities, don't have enough experience or capacity to adequately regulate and supervise the pharma sector, because that industry basically doesn't exist in the countries. 95% is imported. And as such, we sort of have to bridge that gap as DFIs to make sure that the end product that a family, mother of a newborn is buying paracetamol won't risk killing her infant, because that paracetamol is botched and contains penicillin, and that infant is allergic. So it's not a minor It's not a minor point for us. Having said this, AKU is another great example of one of our investments in Africa. And we tried to, as best as we can, to spread out our limited resources. You're right, across Turkey, Brazil, Colombia, Mexico, but also Africa, because the need is great all over. And on your second question of what whether this pattern of investment can change, I can say the short answer is yes. As I mentioned, our traditional instrument has always been long-term debt, and we were able to do about 30% of that in working capital historically. Because of COVID, we sort of decided that we are willing to explore now loans that are medium-term working capital loans, 100% working capital, so 5 to 7 years, for pharma distributors, diagnostic centers, labs, and even to expand our appetite for working capital lines for hospitals and clinics, either to help them move beyond COVID and recover, or simply because certain health sectors have structural needs in terms of working capital. And the last that I wouldn't say is a result of COVID, is actually a result of our internal restructuring. Proparco has now at its disposition concessional lending. We have a large envelope from the French government that we can use to subsidize interest rates, to provide substantial grants, and by I mean substantial, I mean from 1 to 5 million euro grants for specific projects that our clients, for example, in the health sector, might have that go beyond their operation, as we've done with AKU, for example, when it concerns a strategy of cross-subsidizing and allowing the entity to increase access to healthcare.
Super, Claudia. Thank you. Just mindful that you'll have to depart. So we've had a couple of questions in from the floor, which I'm going to pose firstly to Claudia, and I think one of those in particular also we can probably pick up with Michael and Alkarim. So just on the pattern of investment, Claudia, I mean, you said, there's this DFIs, there's a lot of long-term, kind of debt out there. A lot of it's kind of senior. And you've explained about your flexibility and moving more towards a higher working capital loan component and these grants. I guess being provocative, just very quickly, an initial reaction. Some would say, DFIs are in the business of creating markets. And what I've heard is that you're saying there isn't a market, for example, in pharmaceuticals for you in Africa. What would you say to kind of on the issue of market creation and perhaps use of different instruments and higher risk kind of tolerance to kind of help create that? Do you have just a very quick kind of reaction on that? And then I'm going to ask you a question from the floor.
Yes, I think that's part of our role. So when I mentioned that pharma investment that we did, that was market creation. And some of the countries where we're building a factory, it will be the first and only WHO compliant factory. So we were willing to take that risk. And this is an SME. So we gave them, it's an SME that might have revenues of $20 million, and we were willing to lend them $20 million in revenues, and we were willing to lend them $10 million because we knew well the entrepreneurs. We had done an equity investment prior to that, and we've felt comfortable in their capacity to operate quality assets. But it's a very risky investment because they're a small company. And in health, we are also exploring with partners, for example, doing some of the first PPPs in sub-Saharan Africa, where some governments, such as Ivory Coast, is beginning to launch universal health coverage in steps. So at the beginning, I think it's going to cover 15 or 20% of the population. So it's starting, and the idea is it will take time because, as you know, PPPs are not something that you structure in the blink of an eye. So it might take us 2 years to get that project through the door, but that is also market creation. We would be the first ones in helping those types of investments that exist. While in Turkey it's a no-brainer, but we were also the first ones in Turkey to do it. So.
Okay, so just before we go, one question from the floor has been, and I'll ask Claudia this, and then we'll move on to Michael, and perhaps Michael, you can also respond on this. And Alkarim, when you speak shortly, if you could also speak to this question. I think you were going to speak on this issue anyway. But so the question is, once the COVID-19 vaccine is produced, how best can DFIs respond to resource and finance the equitable flow of treatments to all nations so as to ensure no one is left behind? Claudia, do you have some reaction to that question, please? And then Michael, if you could react, and then we'll move on to your questions.
I think it's a hard question when you're operating in the private sector, because those purchases will have, and those negotiations will have to happen at the government level. Having said this, we have been approached by, for example, vaccine producers in large vaccine producing countries to discuss the possibility of financing facilities that could potentially serve COVID purposes, and that we would analyze, I think, like we would any other investment. But I think it's hard because this will not be driven by private sector and one-off companies. It will have to be something concerted by governments, and the type of strategy that each country will want to and will need to apply to the respective countries. So we will support any client that comes to us with a request, and we will analyze it as we would any investment. But it will be more our mother company, the AFD, that will have to work hand in hand with governments to see how they can make that happen.
Okay, thank you, Claudia, very much. I know that you have to depart. If we have any, so thank you for your time and your insight. Very, very grateful for that. Thank you. There are questions coming through, which is great. I'm just saying to the audience that we will get round to those. We've got time built into the agenda, but for the time being, I'm just going to move on to Michael. Michael, I mean, if you can briefly maybe just respond on that question about the vaccine, that would I appreciate that. And then perhaps we can just move on to kind of have a more of a forward look on DFI investment.
Yeah, thanks. And give me feedback if the microphone's not working, please. So on access to vaccines, that is a challenge for the whole world. I do think that the single best vehicle is the COVAX facility that's been built by Gavi, which has signed up lots of allocation from various vaccine manufacturers and aims to distribute them equitably. But they've got a public health mindset about approaching that. I think for DFIs, though, in the future, there may be a role to play for investing in more diversified production facilities around the world. The world is largely reliant on India and China for producing many of our vaccines. And I think one of the things that 2020 has taught us is that governments and citizens value having local production as well as international production. So I think that might be part of the agenda in the future.
Super, thank you very much. So you mentioned earlier that it was surprising, if you like, how little DFIs have done in this space, especially given that low cost of capital. As I said, our research and Claudia's just kind of explained a little bit about why we might see a concentration in hard assets, for example, in infrastructure. And some argue that this kind of lack of innovation or conservative investment approach may be down to their kind of current business models, which frustrate, if you like, kind of risk-taking and innovation. What are your views on that issue?
Well, so I'm going to try to be brief because I could talk about it all day. I do think that the paper you did earlier in the year was really helpful in much of what I identified. I would pick out 5 things that DFIs should think about doing. One is that DFIs should think about explicitly targeting low-income populations, whether it's through cross-subsidy models like Al Karim's terrific Nairobi hospital example or others, but thinking about what impact are we having on low-income clients. Secondly, I think that they're absolutely critical to partner with governments, at least to make investments which are strongly consistent with government priorities for broader healthcare systems, because only the governments can think about the broader system and how they're going to achieve universal health coverage. Third is to bring a public health mindset to the investment. So, MedAccess, every investment we do, we evaluate its potential impact on morbidity and mortality, as well as what the risk is and the financial return on it. So bringing that public health mindset of evaluating quite rigorously, I think is important. Fourth, be transparent about measurement and transparent about trying to assess what is the impact on healthcare. And fifth, I think this is the most important, is really start to innovate more in terms of the financial products and scope. And there's just two things about that. One is most DFIs provide what is essentially senior debt. And with the best will in the world, that's only one tool among many. Is really, really good for infrastructure of various kinds, but it's not going to be the right instrument for supporting a lot of the work that has to happen in health delivery. And a second part of that is think about health systems across countries. I mean, just briefly, if you think about the oxygen supply systems across all of Africa, it's a hugely fragmented market without enough local production. And the risk of investing in any single hospital or any single company with oxygen supplies is it's not going to tackle the whole system. So there's need for systemic thinking and about how the DFIs are going to position themselves in the broader ecosystem. That's hard, but it's really worthwhile doing.
Thank you very much. So what kind of challenges then do you see confronting DFIs in kind of doing more in this space? I mean, and you've also mentioned kind of a more innovative kind of toolkit to kind of overcome some of these, but perhaps you could just speak to some of the challenges you see and what DFIs can do more of.
I mean, like Al-Karim mentioned earlier, I think private investment has a really important role to play in health systems, but it has different roles to play at different times. I think the healthcare needs are broadly divided into three categories. There's people living on less than $5 a day who inevitably are going to need some kind of social support, probably government support, because it's very difficult to produce a wide range of care, goods and services for that population without some government input. So I think anybody looking to invest in that area needs to think about, well, how are we going to get that subsidy in? The second tranche is people who are living on roughly $5 a day to $10 a day. I think it's easier serving that population to look for some commercial return for businesses, but it's still going to require a lot of subsidy. I like the kind of hub and spoke model that some hospitals have developed, where they're the center of expertise and provide services around that, but it has to be with government. I think, ventures that are trying to be entirely insulated from government schemes or working with government run the risk of having perverse outcomes unintentionally. And the third tranche, which is people who are above $10 a day, is obviously the place where the returns are highest, where we have, looking at tertiary care, more expensive care, higher margins, easier to invest in those areas in terms of financial returns and lower risks, but probably not the highest health impacts. So I think thinking carefully about what is the market for health services and how to flex, to have different kinds of investment and different kinds of partnerships for reaching different parts of the market. I think that is a really key thing for DFIs to start to develop. If you've got a model where you're just looking for good bankable investments and you're looking for what's out there, who are the companies, that's not systematic enough. It's not proactive enough. It's not public health focused enough. Really got to think about the broader systems and how to mobilize capital to tackle those challenges.
Thank you, Michael. I'm just going to move on to Al-Karim. So this question actually came up from the floor, so you have an opportunity now, Al-Karim. But obviously, access to health services is a very important issue for your organisation. So addressing this issue about the COVID-19 vaccine when it's available, has your organisation kind of discussed how it can be allocated amongst patients? Will your cross-subsidisation model be applied? And how do you think DFIs can support you in making this vaccine available?
Excellent question. So let me start by saying, and I think Claudia had mentioned this earlier, whatever we do, we have to work in concert with government. We can't act independently, and we won't act independently. So whatever we do will be with the support or the blessing of the government. And we support governments, and we will adhere to national guidelines on beneficiary selection that reflect the WHO Strategic Advisory Group of Experts values framework for the allocation and prioritization of COVID-19 vaccine. given that there is going to be a limited amount of vaccines in 2021, is it essential that we all have this conversation that is going on, how vaccines will be provided, who they will be provided to in the first instance, and to the highest priority groups. Now, having said that, we believe the cross-subsidy model will work on the assumption that we will be able to get an allocation of vaccines in our major urban centers. We will charge those that can afford to pay for them, and we will cross-subsidize and actually give free to those who cannot. That's our intent. We also work in remote parts of the countries in where we operate. So these remote parts of the countries, all governments or government themselves may not pay attention to every part of their population. Not politically correct to say so, but that is the reality. And so we feel that it is our responsibility, again, with the social equity model, that we provide those people, either they're in mountainous regions or the most poorest locales, where they really don't have a lot of political influence, right? So they're not screaming, and the politicians aren't trying to appease them for the vote bank. So we want to work there too, and there we can only do it free of cost. And so the challenge for us is, how are you going to cross-subsidize hundreds of thousands, potentially millions of individuals who have every right to access a vaccine as anyone else? We can't generate that sufficient amount of income. Of course, we'll cross-subsidize to the extent possible, but this is where we need the DFIs to step up. This cannot be concessionary financing. This cannot be loans. This must be grants. The international community, and we know what's happening through COVAX, we know what is happening through EPI, Gates Foundation, and others, but we do need the international development finance community to say, we're going to allocate X percentage of our resources to help during this crisis. And so it's very, very important that that discourse occurs, because we're talking about saving lives. So if I talk about Michael's public health perspective, well, this is public health. So who is going to finance these people who have no voice? Who is going to finance a vaccine for these people who have no resources through no fault of their own? So we have given it a lot of thought. It's very complicated. We don't think it's going to be easy, but I'm glad the international community is having a conversation. I am glad that COVAX and others are very seriously deliberating on this matter. And you know, we're thankful to have a seat at the table.
Super. So just, I mean, reflecting on that, you said, you know, the imperative is it can't be kind of debt financing, it's going to have to be grant financing. So I'm just wondering, and Michael, you might have a view on this, how likely is it kind of that DFIs are going to be able to allocate kind of grant financing for this? Or is it more likely, with your DFID hat on, likely to come from, you know, kind of donors and philanthropics? What do you think on that question?
Well, look, I mean, there's definitely going to be a need for essentially free money for vaccinating the world. And that's in the interests of every single individual who's entitled to a vaccine, but it's also in the interest of global health security. I guess I disagree with Al-Karim, and I don't think DFIs are the best entities to provide those large amounts of grants. I think I would be looking to donor agencies and governments, simply because when it comes to administering grants, the DFIs don't have the staffing and the connections really to, they're not built for that. DFIs are built more for capital investment. So I think on the large scale grants, we'd probably be looking elsewhere, but I completely agree they're going to be needed. And we are facing a year ahead of us in which, you know, many donor budgets have been cut because of GNI restrictions and because governments are short on cash. It's going to be a really difficult process going forward. There's not going to be enough money for what is needed. And therefore, questions about how do we act to mobilize more and how do we allocate what there is are going to require the most rigorous ethical thinking.
Thank you, Michael. Coming back to you, Al-Karim, I mean, I just think, obviously, we've spoken a lot about cross-subsidisation and this access issue, You mentioned earlier that you think that the model is kind of can be replicated, so it's not necessarily specific to your hospital. Can you just talk a little bit more briefly to why you think it can be replicated, and is there a role for DFIs to support that replication?
So Sam, we're speaking just about the healthcare sector or other sectors? Sorry, Sam, you're on mute.
Thank you, Al-Karim. So it's the healthcare sector, so your hospital kind of access model.
Yeah, I mean, why do I think it's replicable? The reality is, is that there is the population is stratified, right? So the people that can afford to pay, and I'll give you an example. Take a country like Pakistan, because we talked about that earlier. There is a percentage of the population that can afford to pay. There is a percentage of the population that goes to the UK, that goes to Singapore, that goes to Thailand, that goes to the Gulf. So they can't afford to pay. By having them be treated in Pakistan, it creates jobs, it keeps money in the economy, it protects foreign currency movements, and that income that is generated literally goes to cross-subsidize those that can't afford it. And so we've been doing this year after year since the first year the hospital opened in the 1980s. And it's a mindset. It's not easy to think, but I can tell you that our patients and the wealthier patients, when they know, oh, well, you know, I'm paying 100, but somebody who can't afford it is paying 10 for the same thing, they actually don't mind. They actually feel good about it, saying, look, I'm paying what is fair and reasonable, which, by the way, is still much cheaper than if they went outside of the country, and I'm helping someone in need. So we have not heard any kind of backlash. We haven't heard any complaints. In fact, we get a lot of kudos for trying to help those less fortunate. The reality is that there are a lot more individuals who require support with their healthcare than we're ever going to be able to provide as one institution or one organization. That is the challenge. So while I've been saying it's replicable, it's doable, I think that we have to just recognize that demand for support for those individuals from marginalized background, that demand will far exceed our supply to provide it. And that's why we need a series of organizations to try and do this. And we complement what government does. We're not trying to compete with government. That is not at all our intent. But, you know, every government, every city, every country just can't be specialists in one area. Just think about the capital cost investment. Think about the cost of developing sub-specialists. It is very difficult. You know, it costs us hundreds of thousands of dollars to develop one subspecialist. The borders in the UK open up, and that investment and that individual is gone. That might have taken you 10, 12 years to develop. So there are challenges which are more macro in nature. But if you're looking at it on an entity by entity basis, I think it is doable. And I will also go as far as to say that, look, we rely on philanthropy as well. We rely on generous donors. But I think donors also get a sense of comfort and contribute to an organization that is thinking about long-term sustainability, and their model isn't 100% reliant on philanthropy.
Thank you very much. So we've had, as I said, a number of questions which have come in from our audience. So I'm going to spend some time addressing those if that's okay. So I think perhaps, Al-Karim, this might be a question for you in the first instance. So capital expenditure on equipment is an absolute necessity on the front line of healthcare, as well as capital costs in surgeries, clinics, hospitals, IT systems and beds. How can DFIs better balance the tension in these two areas?
That's an excellent question. And my answer would be is you've got to bundle it together. So what do I mean by that? You can make an investment. Money is fungible, right? So you can make an investment, and DFIs can support capital investments, and you would repay that money over time. But you also have some of your own funds that you can use and can transfer to critical things like IT beds. Alternatively, you can say, my capital program includes critical investment in IT systems, and I'm going to repay it, but rather than 10 years, for example, I'm going to need 15 years. And I can tell you that the DFIs we've worked with have been very flexible on tenure. As long as they can see reliable and predictable cash flows, and they have confidence in management and in the environment, they will help you, and they will look at it in a holistic manner.
Michael, do you have any kind of response on that question?
Well, I like Al-Karim's answer. I think the thing I would add is that too many private providers are paying above the odds for the equipment that they're getting. Governments are more inclined to use pooled procurement or bulk procurement arrangements, and that can bring down the unit price. The question covered, some of the equipment that you need at the front line and in primary care. That equipment you need is often available at a much lower unit price if there is some pooling of that. And I think we've seen some really good practices, and in fact, the Aga Khan network has helped with, energize pooled procurement among private providers. But I think we need to see a lot more, and ideally ways of pooling procurement across national boundaries when the national need is relatively small, so that you get bigger purchasing power. So I think there's a lot to be done on pooled procurement, including private providers along with some of the government procurement, and that's a place where we can see some big savings.
Karim, do you want to respond from your experience on the ground?
Yeah, Michael's raised an excellent point, and thank you for referencing our organization. So I actually happen to chair our central procurement group, across 12 countries. And we are able to have literally tens of millions of dollars of cost avoidance. And imagine if we could do that and we could partner with other private and public sector organizations, what kind of purchasing power that does lead to. We can deal with the complexities of how big corporations are structured, their regional, national offices, the distributors who sometimes don't have an interest in some of these larger strategic relationships because they're very focused on, making their sales and margins. But I do think there's an enormous opportunity for the public sector and the private sector to work together to drive down these unit costs. And by driving down unit costs, what does that do? That brings affordable healthcare closer to becoming a reality for the tens of millions of people that we're trying to serve in the emerging markets.
Super, great, thank you. So another question that we've had from the floor, and I think we've touched upon probably the conversation just around the, what I always call the love affair with senior debt, but there could be good reasons for that. So what new and innovative models of accessing capital is crucial to reconfiguring the future shape and configuration of the healthcare system itself? Michael, would you like to offer some reflections on that question, please?
It's a huge question if you think about the whole healthcare system. I do think it is useful to think at a systemic level, what does the whole system need and where is capital needed? I also think, as I said earlier, it's really useful to be able to think of multiple countries at the same time. If you've got a situation where a series of relatively small adjacent countries have different regulatory frameworks for different products, it's really hard to find economies of scale there. And so part of what we need to do is make sure that we're making the capital available locally. And I think there's quite a significant need for working capital, and the capital available locally for the distributors, the forward and backward integration. So that is quite different from just senior capital for a large manufacturing project or a large infrastructure project. So I think that probably means providing a greater range of different types of capital to smaller companies, to distributors, to all of those various actors in the ecosystem. Unless you have something like the kinds of networks that Al-Karim sets up, where there's a more integrated approach with everyone under a common investment umbrella with a series of contractual relationships that bind it together. That works great, but we do need to think about the broader ecosystem. And I do think there is a place potentially for using grant funding alongside concessional capital of the kind that, say, CDC uses in its Catalyst framework, and also pushing for universal health coverage. We need to think about, can we use insurance products? The Narayana Healthcare initiative that CDC funds is invested in, for example, they provide catastrophic healthcare coverage for $1 a month for people across Karnataka. That is really cost effective. It works very well. It doesn't cover everything, but it really provides a high level of cover. So that I think more initiatives like that, and thinking outside of many DFIs are still in the project finance mindset, because that's where they started. And we need to think beyond the single project and think about systems.
I think that's a super interesting observation, because one of the things I've kind of observed from my work in participating in this discussion is I guess that kind of holistic approach to investment, rather than that kind of opportunistic approach to investment, and the need for, if you like, DFI investment to complement, if you like, kind of ODA investment made, perhaps, for example, in the UK's case, coordination between CDC and DFID, kind of, and how they approach kind of the health sector. Do you see enough coordination in that kind of regard? I mean, we've spoken about kind of a system-wide approach, complementarity, and also the importance of grants coming up, as one would expect, but DFIs don't usually have those at their disposal. That's, for example, donors like DFID. Do you have any reaction on that?
Well, look, I'm a big fan of combining grants with debt and equity, and also technical assistance in a really smart way. There are risks, and many of the DFIs are going to be under pressure to make sure they're not displacing private capital, and they want to crowd in private capital rather than driving it out. So you have to be very thoughtful and careful about what is the additionality that's being brought to the investment. But I do think there are many cases where a grant for specific services or project development sitting alongside an investment can make a world of difference, especially if you're dealing with the lower income sectors.
Okay, super. So, Al-Karim, I'm going to ask you a question, if you don't mind, which has been posed about universal healthcare coverage. So the question is, universal healthcare focuses on strengthening of the primary health at the primary healthcare level, which is significant in reducing the load on big hospitals. What are your views on investing at the primary care level rather than the tertiary care level?
Another very good question. Thank you for asking that. So I come from the philosophy that life is not binary. It's not a question of and. Do you do this or that? It's a question of and or. And so I think there's a critical role and a critical need to invest in primary care, just like I think there's a critical need and role to play in tertiary and quaternary care. So I would respond simply by saying that investment in primary care is going to require a different type of investor. So whether it's government, whether it's a private organization, it's going to require a different mindset. That is patient capital. That this is the type of money that, wants to invest in 10, 20, 25 years to actually see change come about. So important to recognize that wherever you are in the value chain in the industry will require a different type of investor, but it's absolutely vital to invest in primary healthcare. And frankly, that is a job of government, right? I mean, that is a job of government. This is a job of international organizations partnering with government to strengthen that, because, only 5% of the population generally needs to be admitted. And the vast majority of people could be treated by, a nurse practitioner or a lady healthcare worker or someone who is not a medical doctor. So absolutely critical to have people in that space. and for the international community and countries to support that, but not at the expense of, secondary care, tertiary care, quaternary care. Investment is needed throughout the chain.
Okay, thank you. So I'm mindful that our lunchtime webinar is soon to end. So I just wanted to ask you both quickly. So Michael, just listening and reflecting on the conversation that we've had today, what would be your two key kind of takeaways from this? Perhaps something maybe that you've learned or struck you, and perhaps something, if you like, a recommendation for DFIs, please.
Yeah, I think the two takeaways. One of them is that 2020 really has reframed the problem for us. Governments around the world and citizens around the world are very focused on healthcare and the importance of healthcare for our own security and economic prosperity. So it is also a year in which we've seen huge innovation. It's time to build on that. That's the first one. The second one is, I think that there is a growing potential role for DFIs in this space, but they really do need to, I think, follow some of the innovation, the broader approach to public health, the closer collaboration with government, the smarter differentiation of how they think about systems. And that is all entirely possible. And I expect it will begin to happen more.
Super, thank you. Al-Karim.
I think the two takeaways I would share with the audience is, number one, not only 2020, but I think there is now recognition and broad acceptance that healthcare is a necessary precondition to social and economic development. A nation and its populations are going to find it very difficult to prosper unless they have access to a certain caliber and a certain quality of healthcare. And it's up to each country and each geography to decide where that is. But that is a basic fundamental human right that does require some investment. Otherwise, it's going to be very difficult for a country to emerge. Number two evolves again on Michael's theme on innovation. So if there's a recognition that we need to support healthcare more, and we need to support not only government, but the private sector in helping meet the needs of their growing populations, then what are the tools that should be available? And we have seen great emergence. So Proparco, for example, Michael mentioned CDC, the U.S. Development Finance Corp having a special emphasis on health in recent times. This is all encouraging. I think what has to happen is greater dialogue between the pools of capital and the people actually running health systems. Because if we talk about universal health care, absolutely no reasonable person in my mind could argue against the value of that. But are we really having a conversation as to what are the practical challenges in delivery if you're a public institution or a private institution? So I think there must be more frank dialogue about the issues. And if we're open and transparent with each other, I am very confident that we'll be able to find collectively new and innovative products and tools to help solve some of the most pressing problems in the world today related to healthcare.
Okay, thank you. It's great to finish on that note of optimism. Thank you. So I want to thank the panelists, a very distinguished panel. I've really enjoyed listening to you and learning your perspectives. I just wanted to say to the audience as well, thank you for their questions, and that tomorrow a recording of this webinar will be made available on our website. And also to flag that hopefully you'll be able to join us for our third and final webinar in this event, DFIs and their response in the pandemic, which is going to focus on liquidity issues on the 19th of November. So without saying anything further from me, I've really enjoyed the conversation. It's been a pleasure to have you on the panel, and a big thank you to our audience as well. So thank you, take care, bye-bye.